All right, good afternoon, everyone. Thank you for joining us for this session. We're entitled Hemophilia Federation of America, the Fight for Health and Equity. I am Michael Robinson. I'm the program director for the National Conference for Community and Justice. We are a human relations foundation organization who promote understanding and respect among all cultures, races, and religions through education, dialogue, and advocacy. We work with folks across sectors, students, educators, governments, and the community, all to fulfill our mission to fight bias, bigotry, and racism through education, dialogue, and advocacy. So we can create communities that are compassionate and just for everyone, not just some of us. Today, we have a wonderful panel of folks who have a lot of experience, both personally and professionally, with bleeding disorders, and are here to provide their perspective for us to gain some insight in the way of a better understanding what might be some triumphs that we've seen in the way of advances in treatment for bleeding disorders, but also some of the barriers that we're seeing, especially in relation to racial disparities and how what will it take, from their perspective, through their experience, what it will take for us to get to a place where everyone is able to get the access to the care they need. Today, we have with us, I'm going to read a little information about each one of our panelists to give us a context for who we have joining us today. I will start with Kelly Cribbs. Kelly, if you wouldn't mind waving for folks to see who you are. Hi. So everybody say hi to Kelly. So Kelly's a native of North Carolina and currently resides in Wake Forest, North Carolina, with her husband, Malcolm, and their three boys, Brandon, Braylon, and Bryson. Both Brandon and Braylon have severe hemophilia, factor 9, and have battled inhibitors. Kelly has been a member of the Hemophilia of North Carolina since returning to North Carolina in 2008, and has served on the North Carolina Advisory Board for Bleeding Disorders, Hope Committee, Scholarship, and Advocacy Committees, and has participated in past North Carolina Legislative Days and Washington Days on Capitol Hill. Kelly is also a member of the Autism Society of North Carolina and advocates for those in the special needs community. After graduating from Hampton University with a Bachelor's of Science in Cellular and Molecular Biology and minor in psychology, Kelly has worked within clinical research for over 10 years and currently works within pharmacovigilance as a senior safety manager. In her free time, Kelly enjoys spending time with family and traveling nationally and internationally when safe. Kelly also enjoys gardening and going on culinary adventures. Thank you for joining us, Kelly. Next, we have Shelly Horowitz. Give a quick wave, Shelly. Shelly has been in the field of education for over 25 years. During her career, she has worked as a principal and as a school counselor at every level, from preschool through high school. Shelly has strong ties to the bleeding disorders community with 5 traceable generations of hemophilia in her family. Thank you very much, Shelly, for being with us. Next, make sure they're here. All right. Okay. Next, we have Manuel Lopez. Manny was born in Utuado, Puerto Rico in 1989 and was diagnosed with hemophilia B at 9 months old. From the beginning, his parents did everything in their power to raise him as healthy as possible, but it was difficult to stop the consistent bleeds he was experiencing throughout his childhood. At a certain point in his life, his family decided that it was necessary to move to the United States to seek the best treatment possible for his bleeding disorder. Fast forward 20 years, Manny has been able to actively work and volunteer in the bleeding disorder community in the United States and Puerto Rico. He has a bachelor's degree in business management from Universidad del Este and has owned a small business. He dedicates his life to empowering, motivating, and educating his community to understand that bleeding disorders are not a reason to give up, but a reason to keep living. Thank you, Manny. And last but not least, Dr. Robert Sidonio. Dr. Sidonio is the Associate Director of the Homeostasis and Thrombosis Program at the Children's Healthcare of Atlanta and Director of Clinical Operations and Clinical Research of the Homeostasis and Thrombosis Program. He attended medical school at the University of Alabama, Birmingham School of Medicine, and completed his residency at the University of Louisville Kosser Children's Hospital in Louisville. He is also a fellow at the University of Pittsburgh Medical Center Children's Hospital of Pittsburgh, where he received his master's in science for clinical research. Dr. Sidonio and his wife live in Atlanta with their 2 young boys. Thank you all again for joining us today. Looking forward to the conversation and giving everybody an opportunity to learn through your experience, the wealth of knowledge that you have to offer. So thank you. So to start off, we want to get a sense for how folks have learned about their, how have been tied to hemophilia and bleeding disorders. And so I want to start off first with Manny. And I want to get a sense for how did your family learn about your bleeding disorder, and how did it impact your life from that moment forward? And then we'll get some other thoughts from some other folks.
Can you guys hear me? Hello. So like my bio expressed, I am from Puerto Rico. I was the only person diagnosed in my family, so there's no family history that we can track of. We're sort of still investigating whether the mutation happened with my mother instead of me, but we went back and we just could not find anyone in our family that had hemophilia or anything like it. I come from a really small town in the valley in the mountains in Utuado in Puerto Rico, so it was something very rare. In Puerto Rico, the University of Puerto Rico has a treatment center, and at the time, it was the only place that I could get care. My parents were accused of child abuse because I was just starting to get hematomas everywhere, and a primary care physician, children's physician, in Utuado, had a feeling that it was hemophilia, so he told my parents to get me diagnosed at University of Puerto Rico, and promptly they diagnosed me with severe hemophilia B, and we started treatment there. For the first couple of years of my life, we traveled back and forth. We were a very poor family. We didn't really have access to a lot of finances, so it was very difficult to get to the hospital from where we lived. Our hometown didn't have main highways yet, so it meant going through mountain roads for about 2.5 hours to get to the hospital every single time I had a bleed. There I got put on plasma-derived product and fortunately diagnosed with Hep C not long after. Thankfully, just Hep C, which thankfully I'm cleared of. And it wasn't until I was probably 5 or 6 years old, after a lot of advocating from my parents, that we got home infusions. Home infusions were still not a thing in the island. And if people know how things work in Puerto Rico, we're the only colony in the world, and at this point, our access is really limited. Even till this day, patients have limited access to the treatments they need. And the doctors there try to do their best. But at the time, it was sort of the battle of keeping people alive. And this was in the 90s, where things were in the States were improving. And here in Puerto Rico, we're just fighting to keep people alive. So needless to say, my childhood was not very easygoing. In the late 90s, my parents decided to move to the States to seek out that better treatment and better access so that I could have a better life. But at some point, home infusions did happen after a lot of advocating for my parents. And eventually I started prophylaxis that I continued here in the States, to which I attribute my life, because prophylaxis really did save my life. I don't know if that answers your question, but it shows a little bit of the struggles that I experienced as a child.
Appreciate that. Thank you very much. I'd like to ask Kelly if Kelly wouldn't mind. Manny, your story from your perspective as the patient in this regard. There's a lot that your parents had to do to that had to advocate, and I'm sure I can only imagine what it would be like to learn about this from the perspective of a parent. So Kelly, I'd like to know what was it like for you? How did you learn about your son's disorder, and what was that like for you to process and work to where you all are now?
So for me, it was a little similar to Manuel's story. My maternal grandmother, had a son who was hemophiliac in the 1950s. Unfortunately, in the 1950s, being a single Black female in the South, she was told, how could her Black child have hemophilia? He unfortunately died from a brain hemorrhage at 8. Crying in her arms, "I do not want to die." Fast forward to my mother and her twin sister being born after him. Like Manuel's mother, it mutated with my grandmother. So by the time my mother and her twin sister were born, they now had the gene for hemophilia. Fast forward to me, we knew growing up there would be a risk. My cousin, who's my aunt's son, he had it in the 90s. And now fast forward to me, it was just me and my sister. So I found out once my oldest son was born. I had to actually tell, he was NICU 5 weeks early, his heel prick for his blood test was not healing. I had to actually tell them in the NICU, you need to check because of our hemophilia passed. And they were like, whoa, because to them, they were just tying it up and they were like, oh, it'll heal. I'm like, no. And so because I knew, and because of the struggles of my grandmother, to be proactive with my son. Now the real battle started with the factor 9 inhibitors. Oh my God. I almost tear up thinking about the journey that we went through, because it's very rare, and just the treatment with that. And also, of course, my 2 other sons with factor 9 hemophilia also have autism. So our struggles have been a little different from some. However, we're very grateful for our treatment team. But as a mother, and I know there are other mothers and fathers out there, but as a mother, you feel a guilt. You feel depression. I would say I went through, because I cried many nights, like, what did I do? Or why do my kids have to go through this? And you do everything in your power, going beyond what you possibly can to make sure that they are okay. But it does take a village, because you cannot deal with this on your own. It's a lot. But thankfully, we live in a day to where the treatments are better. And like I said, we have an awesome treatment team.
That's wonderful. Thank you.
No, thank you.
Thank you for sharing that. And you speak to this this generational piece to this, right? If perhaps if you hadn't known about the experience that your family members had prior, and how those situations were handled, perhaps because of things like race or gender. Who knows? Perhaps you're not able to advocate for your sons whenever the time comes.
Yes. I'm strong when it comes to that, because you have to be, regardless of hemophilia, whatever, you have to be an advocate for your own health. You have to ask those hard questions because, we would trust and believe in our physicians and nurses. However, they can only do but so much that you allow them to know. So you have to be proactive with your health.
Much, Kelly. I appreciate that. And I want to open this up to Shelley and Dr. Sidonio. There's both Manny and Kelly have sort of spoken to issues that sort of created barriers in their being able to get treatment, right? Except Shelley, you have an experience of over 5 generations of folks seeking treatment. Dr. Sidonio, in your work, I'd like to talk about what sort of barriers do you see people facing when it comes to their ability to seek treatment that is basic, but also some of the more advanced treatments that folks, and we'll talk a little bit about that more later, but what are some of the things you've seen in that regard? Shelley, you can start, and then Dr. Sidonio. Yeah, go ahead.
So I'm happy to talk a little bit too about my story. So I was asked to come on because of the realities that there's a lot of gender inequity also within hemophilia. So hemophilia runs in my family. There are 6 generations of traceable hemophilia. So there was no question that it was in my family. However, I'm an obligatory carrier. My father had hemophilia, which meant as his daughter, he had to pass it on to me and my sister. And we were both told at a very young age that we didn't have to worry about hemophilia because we were only carriers because we're women. And that is still an ongoing belief, unfortunately, with many medical professionals in the United States. And it becomes a huge barrier for treatment. So much so that my sister was diagnosed at age 42 with mild hemophilia, and I was diagnosed at age 45. So we had significant delayed diagnosis, and I can look all the way back through childhood. I had multiple bleeds. I had knee bleeds that blew up my entire knee and drained all the way down to my ankle, that it wasn't even thought that it could possibly be hemophilia connected or related, but it actually was. And I think as we've had a growing knowledge and as women have started to understand that we too can get hemophilia and manifest it, as we've learned about X inactivation and lionization, which is the process by which duplicate X chromosomes are turned off, randomly causing some of us to end up with hemophilia. I think that we've learned how to advocate more for ourselves and start to understand that women do have hemophilia. We have to really arm ourselves going into doctors and explain processes. We tend to have to bring significantly more evidence to prove that we're bleeding, to prove that we actually have issues. I have blood sisters, my sisters with hemophilia, who have almost died trying to convince doctors that they indeed need clotting factor and treatment. And it's pretty scary when we look at all of those inequities and the realities that women face. We have some amazing, sensitive doctors. Dr. Sidonio is one who have really advocated for us. And I think that we're growing and we're starting to access more treatment and care, and it's critical. It was hard to me to meet men with factor levels double and triple my factor levels and find that they were diagnosed with hemophilia as young men and always had access to factor and treatment. And I didn't get access to prophylaxis until I was 46 years old. So that's a huge difference. And some mild men who bleed a lot will have access as young children. We're coming a long way, but we still have a long way to go.
Thank you so much. And so, Dr. Sidonio, I want to go to you, and I want to. So, what everybody shared so far, we have there's well, self-advocacy seems necessary. It seems like there's a through line in all these stories, right? People had to advocate for themselves in order to get the treatment that some people may be more apt to get and receive, and so in addition to what finance being a barrier, there seem to be some other barriers that may be there too. So I want you to speak to that too, but also how might unconscious bias be playing into some of this the need for self-advocacy in the field of medicine and healthcare?
Yeah, I mean, I think, we're obviously living in quite a different time than even last year at HFA. People are having these difficult discussions that maybe they didn't want to have or avoided them. And so I think it's really hard for some people to understand that there are inherent differences in sort of race and gender and how patients respond and how they're going to bleed. And that's okay. That isn't a form of racism, sexism, or anything like that. It's just very clear. And I think people just don't want to understand that. They think, well, even take, for example, COVID. COVID shouldn't affect anybody differently, but it's very clear. And I think COVID sort of blew the roof off of the health inequities in this country. I mean, start first with the disproportionate number of people of color dying. I mean, there are certain cities in which over 90% of the deaths, like, for example, in St. Louis, are African Americans. And so we don't know if that has something to do with immune system differences. Likely there's a large contribution with economic and health inequities. One of the things that we all talk about with telemedicine is that, this really pushed us into accepting telemedicine, utilizing telemedicine. But what a lot of people didn't realize, I think the problem is the people that were running the telemedicine had good Wi-Fi. They lived in the suburbs. They had access to high-speed internet. And what most people didn't realize is when you look in rural locations, like in rural Georgia, rural Alabama, near where I am, a significant number of people do not have bandwidth enough to do telemedicine. A significant portion of inner city people of color rely on their cell phone for internet access. And that isn't good enough to do an adequate telemedicine visit, and we can't bill for it and be able to deliver the care. And so those are the kind of things that people don't quite understand. And I think those are just some minor issues. And so I'm hoping that, post-COVID, we address some of the issues with Wi-Fi. We address issues of rural and urban access to healthcare to make sure that we're able to apply some of the rules. And when we make rules about masks and other things, we think about different groups of people. We think about different, for example, people, Native Americans have a different experience when it came to COVID as well, and had a devastating effect in that community. And so I think people just need to understand this, not sort of steer away from it and pretend that you can make a single policy and apply it across the board. And then, just taking everyone's examples, my research career got started in women's and adolescent girls' health. And for me, the idea has been to try to come up with very well-constructed, scientifically sound research to convince my colleagues of what I sort of thought was going on. And I wasn't the only one. There are a number of providers that felt this. And you can see the field shifting. And when I look up, and read, I have to do a presentation, I go back and say, let me see what else has been published. I see colleagues publishing papers on this field. And so I'm hoping that we'll move forward with regards to gender. I think because it involves genetics, I think it's complicated for a lot of people to get the concept. I think that's what the struggle is for women with hemophilia. And then, I grew up in deep South, rural Alabama, looking like this. And, I came from, my father's Catholic, my mother's, Italian Catholic from the Northeast. My mother's a South Korean, didn't speak English. And so I understand some of the struggles of trying to sort of integrate without full assimilation into society, where I grew up. And so I understand these issues, and I hope, some of my life experiences, I bring that to when I work in Atlanta as well. But I mean, it is true. We still see patients from rural locations, ones that don't have good access to HTC care, We see patients come in with just terrible joints, patients coming in that have never been treated for their inhibitor. And it just really irritates me and just kind of pisses me off that, they were not offered the same access to care that we offer to all of our patients at our center. And so those are the kind of things I think we need to do a better job. I really hope that, people of color really start to participate more in some of the data sets. That's one thing that they don't like to talk about. And when you look at sort of the large national surveillance data sets, there's a significant underrepresentation by Hispanics and African Americans. And, we're not going to be able to understand their experience, the differences in the way care may be delivered to those patients, and how they're responding. I mean, when you look at things like leukemia, for example, I know it's totally different than hemophilia, but there's different response rates based on ethnicity. And so clearly there has to be a different approach to make sure everyone achieves the optimal outcome and similar outcomes. And that's going to require a complete effort from the whole community.
Thank you so much. I appreciate that. I want to go back to some of the themes from folks sharing some of those their inequities in treatment. It seems that gender was something that was sort of paramount in either misdiagnosis, not being diagnosed. Kelly, you said that your grandmother who was just so told flat out, you can't have hemophilia because you're Black. It can't be that, and so that there's in some cases there's blatant bias, right? There's people are saying that women are only carriers, so you can't have hemophilia. You're Black, you can't have hemophilia, right? I want to. How is that? So there's that overt bias, but the unconscious bias is impacting people in a way perhaps that they're not necessarily even aware of. Have folks? And I'll start with Kelly. Have you experienced anything in your over time as you navigated this this new world with your sons, where you have seen where perhaps unconscious bias is in play and impacting your treatment or how you're being treated by someone?
Yes, both professionally and personally. Like I said, you have to be an advocate for yourself and for your child. And it's essential because it's been plenty of times, even for me, when Shelley was talking about females and having bleeding issues, as a carrier, there are some times growing up, I can relate, and even now, and I think in the back of my head, like, and giving birth, and even with those issues, but just advocating for them, and telling physicians and going to the hospital, they do not have factor VIII. It's a misconception that majority of people of color with hemophilia bleeding disorders are factor VIII. No, they're factor IX. I'm factor IX when I was delivering my my youngest son. And still to this day, we have to fight just for basic, knowing what's on your medical charts, looking at that, discussing things with your physician, with the nurse, when you go into the ER, because unfortunately, those unconscious bias exists. And that's just unfortunate because we have these, preconceived notions in our head, but we're too scared or afraid to ask. And the only way you will really find out something is to ask.
I appreciate that. Mm-hmm. Speak for ourselves. Manny, or would you like to speak to some of your experience with that as well? Have you seen any of your care where you had to sort of advocate in more heavily for yourself or for other people that
Yeah, so I think as I heard Shelley and Kelly speak to their experiences, it brought me back to the current political situation in Puerto Rico and how the reality is that the access that's available on the island has been limited to the political umbrella that has been put over the island. So, when you're in Puerto Rico, you have a lot of diversity there, the majority of the people there are Puerto Ricans, so you can definitely experience some biases. I think gender bias is a huge deal that anywhere you go, you're gonna see that being expressed. In my case, I didn't really experience necessarily gender bias. The reality is that when I was young, the majority of the patients there were male. Like very rarely you saw women there or girls because of what Kelly and Shelley expressed. Like the reality is of those diagnoses not being expressed, and I agree to the point where having that diagnosis in your chart and knowing what's in your chart is so essential for you to advocate for your care, because once it's written, you can't really undo it. There's concrete evidence that you have what you have. In my case, as I look back, I just see the inequality of access that Puerto Rico in general has, which has influenced the medical system. I've lived in the States, primarily in Pennsylvania, and I've lived in Puerto Rico on and off. So I've traveled and I've lived for periodic periods of time between Pennsylvania and Puerto Rico. And I decided after high school that I was going to go back to Puerto Rico because my expectation was that care was going to be up to the standard that was in Pennsylvania, with Dr. Ragney and her HTC. So my expectation was really high, but yet when I got there, the system showed me that they were barely halfway up. I had to leave my little town in Utuado at 3 a.m, drive 2 hours to wait to get on a first list that will give me access to a building to then be able to put my name on a secondary list so that I could wait for my doctor to arrive at 10 or 11 a.m. to then see them for about an hour and get sent home. For people with low income, that was unacceptable. Like they just couldn't make it happen. And I lived across the island. So luckily I had access to a vehicle, but when I first moved, I had to pay for public transport to get there. And it was not something that was fairly accessible. So, I look at how the economic situation, the medical situation, the political situation in Puerto Rico has been sort of brushed off and has been ignored for so long that now it's COVID, I think, like Dr. Sidonia said, has exposed a lot of these issues. Needless to say, the political situation, the economic situation, and the downfall that the island has expressed. So I think from looking at it from a perspective of inequality to care, I think, unfortunately, we have to bring the politics to it. Inequality to an island that has been disregarded and rejected by the United States and has not been given the access that it needs. So I think as patients, we really do have to advocate for that. But as citizens, we need to advocate for that everyone in the United States, so that everyone in the United States gets the care that they deserve as human beings. And I have to give props to the Puerto Rico Hemophilia Associations that they're doing such a good job, and they're really pushing so that the doctors there get the funding they need so the patients can have access to a clinic. For 2 years while I lived there, I had no care because federal funding was cut and the adult clinic was shut down. So I had to go to an oncology clinic, sit in a room with 100 other oncology patients. I was the only hemophilia patient to see my hemop doctor, who was to the brim with work, where she just had so many patients to see that it was difficult to get to see her. And I had to go through the entire process of being out from my house at 3 a.m. to be seen for 5 minutes, which as a patient, that's not good care. I had no access to a social worker. I had no access to a physical therapist. I had no access to anything besides lab work that I still had to drive 2 hours away to go to get because it needed to be in the center where it was more trustworthy. So I think the inequality, unfortunately, for Puerto Rico has to be taken to a political spectrum, unfortunately, because that's the reality.
Thank you. Well, and I want to get your thoughts on this from your perspective. Seeing this throughout your family for 5 generations, but also speaking to gender and we've seen some of that international perspective that Manny's providing. So how's your family been impacted by some of the things that have been discussed so far, but also leading to this next question. Do you believe all people with bleeding disorders have always had equal access to breakthrough treatments? It sounds like there are some folks have had to do some extra lifting to get to the same types of treatments that other people seem to just have readily available. And so I'd like perhaps for you to speak to some of that as well in your remarks. Go ahead.
So no problem. I'll first just really briefly answer your unconscious bias because I think it comes up a lot with women and gender equity. When we look at our national conferences, and I appreciate that HFA and other organizations are really stepping up, as Dr. Sidonio said, and starting to have these conversations. But oftentimes when we walk into a national conference, we might go 3 sessions and not hear one mention of a woman with hemophilia. So when we look at photographs, it's all men. When we look at our products being advertised, it's all men. If a woman is on an advertisement, they are usually the supportive parent or spouse. In the advertisement, they are not the patient themselves. When we look at stories of hemophilia, it's male pronouns. When we go to workshops and they talk about case studies, recently I was listening in on one that dealt with mild hemophilia and mild phenotypes. Every case example was a man. And in multiple of the case examples, I knew women who actually had more severe bleeding issues in their joints, not female bleeding, that could have been used, but they're not being used in the example. So you see where even among our own community, the unconscious bias is so entrenched and so accepted. Women, when they do have workshops, it's also often about bleeding and menstruation. And many of us women want into the men's joint workshops because we're having the same issues with joint bleeding. And I think that those things are shifting. But I did have a woman recently say, I am more than my uterus. And in the hemophilia community, I need to be addressed as being more than my uterus. And interestingly enough, when we look at access to care and we look at that equal access to care, when we start looking at aging, in some research studies, it shows that men's factor levels actually increase with age. But for women, we lose the protection. Some of us, particularly the A's, hemophilia A, we lose the hormonal protection, which actually gave us a factor boost. So some of us find that our factor levels are actually dropping and we're having more of the joint issues and more. But it's all anecdotal at this point because research hasn't really been done on women and aging with hemophilia. So we need to get more of that research out. But I guess my final, just in terms of unconscious bias, what I would say is that we need to consciously include women, people of color, anyone who's being left out. We have to consciously ask that they be included until we get to the point as a community that we're including regularly. So when we ask someone to present on mild phenotypes, we need to say to the presenters, you need to include examples of women and minorities. And we need to actually instruct them until our community until it's normalized and they know to do it automatically, because right now it's not happening automatically. And then barriers to care, I think everything I mentioned is ultimately a barrier to care because it reinforces to the medical community outside of our hemophilia bubble that these biases exist, and then that reinforcement drives our lack of access to care. And as Kelly and Manuel have said so beautifully, we have to be incredible advocates. Women have to bury their providers in information and examples of why they bleed and need care. And hopefully we'll change that with, over time. These discussions are critical, and I'm so glad we're having it today.
Thank you, Shelley. To borrow a line from one of our sister organizations, if we're not being intentionally inclusive, we run the high likelihood of being unintentionally exclusive. So that intentionality is key. Dr. Sidonio, I want to turn over to you. So everyone so far has talked a lot about barriers, and I want to go back to something you said earlier. You suggested, people of color and women, they need to be a part of these survey, this research, right? So that we can ensure that the sample size is too small right now. And perhaps can you speak a little bit to why you think that might be the case, or either why you think that might be the case, and also what do you think needs to be done to be intentionally inclusive for researchers to ensure that they are including women and people of color in their the research for moving forward?
Well, I think, I'll give you an example of sort of how to target. So I previously had worked in sickle cell, and one problem that was sort of an issue was this idea that traditionally African Americans were had a very small representation of the donated blood supply. And that had a really big effect. So people with sickle cell disease often require blood transfusions, disproportionate amounts when they have pain episodes, acute chest, other complications. And then similarly, when it came to bone marrow transplant, if you were biracial, for example, or African American, there were less donors that were biracial and African American. And so my previous mentor sort of had a strategy, and he worked with other groups that did similar strategies. So he was African American, and so he worked with sort of local organizations, and they said, well, how are we going to reach this community to get blood transfusions? And he actually was able to create an initiative called Sickle Cell Sabbath. So he actually went to the churches, spoke at the churches, and then had blood drives after the churches, and then was able to increase the amount of blood donations so much so that they were able to actually send blood from St. Louis to Philadelphia and other places that needed it for sickle cell. And so, that's why when people sort of poo-poo the idea of diversity and sort of organizational structures and such, the problem is that people have blind spots that are just that unconscious bias. They don't have that personal experience, right? I mean, we all have our own experiences and how we grew up, and they're not all the same. We're not all monoliths. Blacks only vote a certain way and such. And so it's important to have that diversity in the organizational structures, because then that helps improve and your problem solving that may reach those targets and actually solve those problems. And I think, it's just like the census, they're not, right now it's not being as good at documenting people in the inner cities, documenting as well people of color. And that's going to have major consequences in the future. And so I think there needs to be people involved in our ability to try to encourage patients. I grew up in Alabama and remember reading some of these stories about terrible research experiments, like the Tuskegee experiments, in which they were doing these syphilis experiments. These were done all the way up into the 1970s. There was no reason to not treat patients with syphilis at that time. We had a simple solution with penicillin, but there was an unethical study that was going on at the time. And so in the South, and we see this when I was working in sickle cell, there is a huge distrust of the medical establishment because they don't think that they're sort of have them on their side, and they think they're performing experiments. And I also think there's just a misunderstanding of what surveillance is. I often will hear people say, well, you're not going to experiment on my baby. You're not going to, you're not going to treat him like a guinea pig. First of all, we don't use guinea pigs that much in experiments anyway. We use mostly mice. So I usually start with that. And then, these things are surveillance studies, right? These are projects in which we're following patients prospectively. We're de-identifying this data. And if you don't have representation, when we start publishing data, it's going to be a very small percent that are African American. We're not going to be able to do any analysis in any other groups, and you're going to be lumped in all together in one big group. And so that's not going to benefit anybody. And so that's where I think, I think groups like the CDC and Athens have been trying to do a better job of this, and probably should reach out to organizations that may be able to offer some solutions that they just may not understand sort of how to get to these groups. And, and so I think, that's why I think it's really important to have that diverse inclusion in your infrastructure. And there are groups, I work with organizations like ASH, and we try to avoid things like manels, we jokingly call them, where it's all a bunch of dudes on a panel. And that is a huge problem. I mean, even if you look at organizations like ASH, I mean, 5-10 years ago, it was predominantly male speakers, Caucasian male speakers from the US. But with intention, and it really wasn't that much more difficult. It's about half. Basically, the representation on the panels represents who's the members, and clearly, I think we're going to all benefit from that inclusion. We don't need to hear from the same person over and over about the same topic. We can hear different people's experiences. That's when people ask me about women with hemophilia. I said, there's other people that can talk about this too. It doesn't have to be just me. So.
I appreciate that very, very much. And great kudos to the folks who put together this panel, because this is certainly not a mantle. So
no.
Very, very, very nice. Very nice. So speaking of research and new therapies, and I really appreciate you, Dr. Sidonio, talking about, the importance of organizational structure, right? We have to have diverse organizations in order for there to be diverse representation. And to be conscious about that. And actually it sounds like too, there has to be an awareness and a willingness to acknowledge that there perhaps are things that folks need to, or are not doing, or may not be aware of, that they need to be aware of, right? So it's sort of part and parcel, or it takes both sides of that. The organization has to acknowledge that maybe we do need people, and then we have, and then we do have some areas that we need to be focusing on that maybe we don't. And so, I want to open it up to talking about overall, and I think we've touched on this for certain, but what types of disparities and inequities do we see within the bleeding disorder community? Right? We talked about gender, we talked about race, ethnicity, right? We got some international perspective, but from your vantage point, and I'll start with Shelley, if you don't mind, Shelley, to give some insight. So where else do you feel like you're seeing some of those disparities show up, and especially as we think about new therapies, new treatments, things like that? What should we be aware of?
So those could almost be two separate questions when we look at additional disparities and disparities in new treatment and access. Without a doubt, there are individuals who are still struggling to get treatment. And again, that's what all of us on the panel have been saying, and the need to prove that you're bleeding. And I will say that I don't believe it's just women. I have heard stories of mild men struggling because, there's this severe kind of understanding of there's an understanding of hemophilia as being severe. So there have been mild men who have also struggled to access care. And it's as though the burden of proof is on the individual seeking care. And that can be really dangerous for someone looking at care. When we're looking at new therapies and access to therapies, which I think is a really good question, there are a lot of different factors involved. More often than not, when you're looking at new treatments, they tend to be focused on individuals with severe hemophilia, at least in the beginning. They're looking at treating the most severe. And sometimes you'll see studies come down the line eventually that look at women or individuals in general with mild hemophilia. There are a few out there right now that are allowing individuals with mild hemophilia and even women in if they agree not to become pregnant, and a few other issues that tend to come up when they include women in studies. I think some conscious studies on women and individuals with mild hemophilia are needed. And Dr. Sidonio has tried to do some of them, and he's definitely included research, and I'm sure he can tell you about trying to find individuals to participate in research as well when it comes to women in studies. I do think that is definitely still an issue. I think that for our drug companies developing treatments, the severes are more likely to use the medication more frequently. So there's that focus. That said, I think that there are many mild individuals who are bleeding and struggling more than we have ever realized. And I think that they've been pushed aside because of when you can't compare my bleeding to someone who's severe, but I have photograph after photograph of the fact that I actually was having bleeds on a monthly basis. So many of us milds were watching the severes get treated and be bleed free. They talk about being bleed free for a year even, and we didn't necessarily have that same access. So I think that it's really important to look at all the aspects of research and who's included and not. And I'm going to stop because I see some of the other panelists have some good comments to add.
You started to, I think, speak to the non-severe hemophilia treatment, right? And who'd like to go first? Kelly, would you like to maybe chime in and give you some of your thoughts on some where you see some of those disparities showing up?
Well, first, I do want to, like Dr. Sidonia has commented, we do need to recognize our von Willebrand's community, our rare factor 7, factor 11s, factor 5s. We need to acknowledge when we say hemophilia, that is an unconscious bias within itself. We need to recognize the bleeding disorder community, like autism, as a spectrum, because one person does not bleed a lot, does not bleed the same. When we go to conferences, a lot of times it's heavily focused on factor 8 and factor 9. And as a mother who has factor 9 hemophilia, I get it. You may feel left out, for someone who has von Willebrand's. They feel left out sometimes because they maybe have one session and that's it. The main talking points for treatment may be about gene therapy for hemophilia, and that's fine. However, you have to discuss bleeding disorder community as a spectrum. So I do want to acknowledge everyone who may be listening who doesn't have factor 8 or factor 9. We understand you need to be included because, we have treatments factor 8, but the treatment for those individuals is even more scarce and rare. And just for them to even get diagnosed, wow. So I know, Dr. Stone, you may want to speak more to that from a medical side.
Sure, thanks. I think, Kelly's right about this and what Shelley said and Michael, but, I think it's great that we've spent a lot of time putting our efforts into taking care of our severest of patients. I mean, that was the impetus of starting the HTC networks, the government getting together and putting a surveillance network so we can catch things early and not have, never have anything like HIV and hepatitis C again. And so, so I think, now that, gene therapy obviously was delayed a few years, but there are a number of gene therapy trials. There are a number of non-factor therapies, extended half-life products. But when you take a look at things like von Willebrand disease, there's only been a single new product in the last few decades. And, we do have some reasonably good products for von Willebrand disease. But I think the way that the government and the FDA sort of looks at von Willebrand's is sort of look it through the lens of hemophilia and want trials the same way, want, recruitment and enrollment of patients the same way. And it's just not going to work out. I think that's been very clear trying to do prophy studies at von Willebrand's. But I think, moving forward, the HTCs have to evolve. I mean, there's a significant increase in the number of women coming to the centers. And so we need to have GYNs and adolescent providers in our clinic. That's just something that makes sense. That's something everyone should be thinking about. And we really need to sort of, I think it's a good time with the von Willebrand guidelines coming out later this year, that we really start to focus on von Willebrand's, particularly in 2021. I think we need to start thinking about new therapies, new approaches, and how we can design prospective studies to really attack this issue. I'm involved, thankfully, with the support of Athen and Takeda as a pharmaceutical company, where we are running an Athen 9 severe von Willebrand studies. I'm hoping to see other companies come forward and really try to have a concerted effort in taking care of those patients. Because right now, drugs like emicizumab are making severe patients more like mild, moderate patients. And now moderates are becoming the new severes. And so I think we really need to start focusing our effort. We really should focus our efforts on moderate hemophilia. I think that's just such an easy target. At least half of those patients are on prophylaxis anyway. And so clearly the bleeding tendency, and as we elevate our care, we're going to see more and more moderate patients on prophy. And then that's just going to keep moving and moving. And hopefully, you start to see this, there's the Haven 6 trial, which actually includes moderate and mild hemophilia A patients, and it also includes women. And so I think that's really important. And its companies need to really sort of understand the importance of including those patients in studies, because we're going to get such valuable information. And we shouldn't just rely on a single case report here and there and say, there you go, we got 3 women with hemophilia on a drug. That probably is going to work okay. I mean, that's good for us for insurance company, but, we really need to sort of look at this, because I'm sure we can come up with strategies to take care of our, non-severe patients.
Thank you so much. So we have a little under 5 minutes left in the session, and so I wanted to give an opportunity for everybody to have perhaps some moments to touch on. We've talked a little bit about what diversity looks like in clinical research. What types of the intentionality that we need to take to move that needle forward, to make sure that as Kelly was saying, the spectrum of folks who are experiencing bleeding disorders is taken into consideration. And so I'd like and we start with Manny and then sort of go down the line, and I'll prompt who can speak. But what steps do you feel need to be taken to ensure that that future treatments are equitable and accessible to all people? And I'd like to add another piece to this is who might need to be considered as part of new trials moving forward, in addition to those who've already been mentioned in the conversation. So Manny, I'd like to start with you, and then we'll go Kelly, Shelley, and Dr. Sidonio to round us off. So.
Yes. So I'm glad that you asked that question, because as Dr. Sidonio was speaking, it just really triggered a lot of things for me. I'm technically a moderate patient with, 3% factor IX levels, and my bleeding episodes have always been severe. And in the past couple of years, I've considered entering in some of the trials, and just because I'm 1% above the 2% max, I can't join it, even though my experience as a patient with hemophilia has always been with severe bleeds. And I think a lot of that too is due to the fact that I had limited access as a child, and during the time that I was back in Puerto Rico, because I had limited amounts of factor and doses that were a third of what I was supposed to be infusing, I developed a lot of hemorrhagopathy. And unfortunately, I have a right ankle that's prone to bleeds, and for the past 2 years, luckily with the product that I'm using, I was bleed free in my ankle, and I had never experienced that for 31 years of life. 2 years without bleeds in that ankle was something that was awesome. And just a week ago, I had the silliest twist in my ankle, and I had a full-blown bleed. So seeing that, it just triggered a lot of memories as a child, struggling to get that access, and also as an adult trying to join studies that could provide a doorway for new treatments for people of diverse cultures. I was really frustrated with the system where just because of one percentage level, I was not able to be included. And the reality is that when they're going to roll out these studies, they just need to include that from the beginning. And I realize that they don't want to necessarily their data has to be as pure as possible, but then I think the studies need to be developed in a way that is inclusive to not just men with mild or moderate levels, but women that have diverse levels. I think the reality is, and to Shelley's point, is that I've sat in a lot of ad boards, and the majority of the conversation is about males, and you hear about their studies and everything's about males. So I think we need to tap into women, and we need to make sure that they're included, and people from diverse cultures are included. And I'll close this by telling Kelly and Shelley that a lot of the guys, and I would say the majority of us, are out there advocating for you, where you're not alone. If you're a woman that's out there that needs the attention, please know that all the males in this community are out there advocating for you, pushing for you, and if you need anyone, we are here for you.
To ensure equity and accessibility.
Just trying to see if I don't know if we're going to get cut off, but just to make it kind of short and touch on something that hasn't been really discussed. And it's just, from my perspective, personally, I have a story, and professionally, having been in the clinical research industry for over 10 years, honestly, it's getting to where the people that design the studies, write the protocols, are at the pharma companies, understand the need for diversity in clinical trials, understand just basic when you ask sex, it's no longer male or female. There are so many other people that identify different ways. We need to be inclusive all around the board. Also, too, when you want to have these trials, you have to have diverse people at the board designing these clinical protocols. Also, looking at talking to the physicians of the importance of having diversity. I'm so glad that Dr. Sidonio raised that issue of reaching out to people in the community who know how to reach those people that need to be in these, because to be honest, a lot of people aren't even asked. They assume, well, they're not interested or they don't want to do it. Well, did you ask them? Just simple ask, but also too, having the people at Big Pharma and clinical research industry have diverse workforce and fields. And to that point, my last point, thank you so much, Rainbow, for saying there are males out there who are working on our side. And also, too, I wanted to say, even with me and being in clinical research, I raised that point and have started a diversity in clinical research training with my company to train physicians and investigators in trials of this unconscious bias to make sure we have a diverse clinical trial and participants.
That's amazing. Shelley, do you have any thoughts you'd like to add before we wrap up?
Yeah, thank you. I agree with everything that's been said. We have a great panel today, and I would really like to emphasize an answer to your question that we need to really work for conscious inclusion of people in our community, and that's women, that's men and women with mild and moderate hemophilia, that's people of color, that's individuals with von Willebrand disease and other rare bleeding disorders, and really understand that bleeding phenotype and genotype can be very, very different. Mild hemophilia ranging from 6 to 40 or 50% is a huge range. And for those of us women who are at the very bottom of that range, we really bleed more like moderates and severes. And I know that there are other mild men in the same position. So I think just being more open to that conscious inclusion and to understanding that we all have our own stories and we need to get the message out to not just our community. We start with our community, but then out to general medical providers, that there are multiple categories of individuals who need better access to treatment and care.
Thank you so much. Dr. Sidonio, do you have any final words?
Yeah, I mean, this is a great panel. Normally I'm involved in medical panels, and it's nice to be able to have, discussions like this. And I don't know, I'm assuming we would have probably had this. We probably are reaching a larger audience because of sort of the way this is being reached, and maybe there's not as much competition in these things. And so I'm just grateful to be a part of this. I'm hoping that, when we have challenges like COVID, it sort of exposes some inequities, and we address those inequities instead of just turning our, the other way and walking the other way. And, just what somebody asked about sort of gender identification, you're starting to see that in the ATHIT data set, for example. They actually changed this recently, because I noticed when I looked under transgender, there was only one patient included. And I thought it's highly unlikely there's only one transgender bleeding disorder patient in all of the United States. But obviously they've changed the classification, and they add things like when a woman has their first period, because when they created these data sets, they were aimed at men, And so you're starting to see concerted efforts, like Shelley said, and those are only going to make things better for all of us. It's not making it better for a very small group. It makes it better for all of us. And I think people really need to understand that this is better for all of our community.
Well, thank you all so very much for sharing your stories, sharing your wisdom, and being willing to bring the truth to this forum. I really appreciate what you all had to share. Keep fighting. People change the world, right? We are the society. So, like you said, Dr. Shadonio, something that helps some of us will eventually help us all. So, thank you all for tuning in, for being a part of this experience. Those out in the audience, I really appreciate you as well. So, thank you very much. Have a beautiful evening.
Thank you, everybody.
Thank you.
Thanks, everybody. Be safe.
Thank you very much.
Have a good meeting.